सो हेलो लर्नर्स। आज एक बहुत इम्पोर्टेंट टॉपिक विच इज़ वेरी इम्पोर्टेंट एंड ऑडिटेबल टॉपिक ऑल्सो, एंड दिस इज नोन एज शोल्डर डिस्टोशिया। इट मीन्स कि जब हेड की डिलीवरी हो जाती है और शोल्डर बाहर नहीं आ पाते हैं, सीन ओनली इन कैफ्लिक प्रेजेंटेशन, उसको हम शोल्डर डिस्टोशिया बोलते हैं। Although it is very rare, 0.5 to 0.7 to 0.1% to 1% of the deliveries may reported है, बट जब ये होता है इट इज वेरी हार्मफुल बोथ फॉर मदर एंड द बेबी एंड यस फॉर ऑब्स्टेट्रिशियन ऑल्सो. So first and foremost, what is the definition of shoulder dystocia? So definition is when head to body delivery time is more than 60 seconds. तो यहाँ पे 6 की फिगर बहुत इंपॉर्टेंट है. So when head is delivered and body has not delivered within 60 seconds, we call it as shoulder dystocia. So as you all know, I've already told it is an obstetric emergency. जैसे ही ये condition diagnosed होती है, urgent call for help should be sent. So we will revise all the concepts of shoulder dystocia today in this presentation. I'll try to use this whiteboard, which I'm not very well versed with, but let me try. So, okay, we can use text also here. So I'll erase this, whatever was written. So in the text, I'll just write that shoulder. I think this is also taking much time. I'll just speak. Basically, I wanted to show certain mnemonics and maneuver. So yes, I'll speak for now. Shoulder dystocia is a condition seen in Catholic deliveries to the range of 0.5 to 0.78% of the total deliveries. And it is defined as when the interval between delivery of head and the body is more than 60 seconds. We can have significant perinatal morbidity and mortality associated with this condition, even when we manage it properly. Incidence of postpartum hemorrhage and third and fourth degree perineal tear, desiccation of symphysis pubis, and long-term lateral posterior cutaneous nerve of thigh paresis has been seen as maternal complication of shoulder dystocia. For fetus, obviously, asphyxia is one. Brachial plexus injury is one of the most important fetal complication of shoulder dystocia, and it complicates around 2.3 to 16% of such deliveries. Although most cases of brachial plexus injury resolve without permanent disability, but 10% result in permanent neurological dysfunction. And if we talk of UK, this is the most common cause for litigation associated with shoulder dystocia. So basically what we have to learn first, if it has been happened, if it is happening, then could we have predicted shoulder dystocia? So one most important thing that you should remember is existing risk factors for laboring women, and we should always be alert to the possibility of shoulder dystocia in presence of risk. So risk factors associated with increased incidence of shoulder dystocia are: one, during labor, previous history of shoulder dystocia, having a macrosomic baby more than 4.5 kg in Western world and more than 4 kg in India, although literature around this is less clear. A pregnancy complicated with diabetes mellitus, having maternal body mass index more than 30, and induction of labor. So these are the factors which are present before labor by which we can predict that yes, this patient can land into shoulder dystocia. Intrapartally, when delivery is happening, then you should always be suspicious if the patient is having either one, prolonged first stage of labor, second, she fails to progress, that is known as secondary arrest, third, there is prolonged second stage of labor, fourth, if you have used oxytocin for augmentation, and fifth, there is assisted vaginal delivery. So these are the these are the risk factors, and you can use it to predict shoulder dystocia. Second question comes, how can we prevent? So first was prediction, where you are more alert that your patient can land into shoulder dystocia. Second is prevention of shoulder dystocia. So we would like to talk about few points. One is induction of labor, because many a times we see that some authors are suggesting that labor should be induced preferably at an earlier period of gestation, so that growth of the baby is not excessive and we can prevent shoulder dystocia. So let us be very clear about this, that it is not recommended. So induction of labor does not prevent shoulder dystocia in non-diabetic women with a suspected macrosomic fetus even. कब करेंगे हम इंडक्शन ऑफ लेबर? जब शोल्डर डिस्टोशिया का इंसिडेंस हमें कम करना है उन फीमेल्स में जिसमें gestational diabetes mellitus है. So if you're caring for a pregnancy in which a patient has developed gestational diabetes mellitus, there there is definite role of induction of labor to prevent shoulder dystocia, and you are well justified to induce your patient for the prevention of dystocia in diabetic pregnant patients. But routine induction of labor for the sake of prevention of shoulder dystocia in non-diabetic patients is not recommended. So I think we are clear over this point. Second point is elective cesarean section. If you're suspecting macrosomia, because that's a common reason we give for doing elective cesarean section nowadays. So few points for importance is, one, elective cesarean section should be considered to reduce potential morbidity for pregnancies complicated by pre-existing or gestational diabetes, regardless of the type of treatment she is receiving, where there is estimated fetal weight is greater than 4.5 kg, again in Western world, and 4 kg in Indian scenario. So wherever you find or you're caring for a pregnancy which is complicated by diabetes, whether it is pre-existing or gestational, whatever type of treatment she's taking, whether she's controlled on MNT, insulin, or oral hypoglycemic agents, if her baby weight is more than 4 kg in India and more than 4.5 kg, then you can plan an elective cesarean. So I think we are pretty clear about this point. Second is, if a patient comes to you and she gives you a history that her previous pregnancy was complicated by occurrence of shoulder dystocia, then you can either give her the option of cesarean section or a vaginal delivery after proper discussion with pros and cons of both the modes of deliveries. So it's not mandatory that every patient who has had shoulder dystocia should be having elective cesarean delivery in this pregnancy. Neither is that like if you go for vaginal delivery in a patient who had shoulder dystocia in previous pregnancy and you are committing some crime or you have done some negligence or you're wrong. It is not wrong. But yes, the patient as well as you should understand the pros and cons of both the things. Proper counseling should be done and it should be documented. Now, as majority of the macrosomic babies don't land into dystocia, and majority of the dystocic babies are not macrosomic. So nothing and any of the risk predictors models are 100% effective. In fact, there is very poor predictability around these prediction models. So you have to think that any patient can land into a shoulder dystocia. So you have to be prepared. And that is why we recommend drill associated with preparation of shoulder dystocia, both for doctors as well as for nursing staff. So, um, yes. So now we will talk about actual management of shoulder dystocia. So you must have heard about mnemonics associated with management of shoulder dystocia. One is how to diagnose. So it's not like every patient who is having a protracted second stage will be having shoulder dystocia, but the factors associated around second stage should raise an alarm that yes, this patient is going to have shoulder dystocia. So here, okay. So first is diagnosis. How to diagnose. It is very important because sometimes I've seen even senior residents standing there, not even knowing that they are going to deal with a case of shoulder dystocia. They're just putting on lot of traction over the neck of the fetal head, and thus there are a lot of injuries. So making a diagnosis of shoulder dystocia is as important as timely and promptly managing. So how it is diagnosed? One, if you face difficulty with the delivery of face and chin. So that is point number one. So when you are delivering head and there is difficulty in delivering face and chin, remember this. Second is you have delivered the baby and the head fails to restitute. It is very important. And I have seen sometimes people, they are by force trying to restitute the fetal head just to hasten up the delivery, not knowing that this will bring in the further damage. Third is the head is remaining very tightly and closely applied to vulva, or even as you deliver it out, it retracts back. And this is known as turtleneck sign. And turtleneck sign, just be very, very alarmed by this because this brings a lot of asphyxia because there is a compression over fetal neck also. Then further, you can uh, diagnose shoulder dystocia when there is failure of shoulders to descend, especially when you have applied moderate downward traction, which you do routinely to deliver the fetal shoulder. So there is no descent of shoulders. So I think we all should suspect, and this is very important, as to postgraduate graduates in their examination. How do you diagnose shoulder dystocia? So these 4 points are very important. No descent of shoulders with gentle traction. Then I always tell that if you have augmented any patient and there is undue delay, then there is a classical teaching method of saying that either there is fault in pelvis, passenger, or power, that is contractions. So when there is, whenever you feel there are good uterine contractions, patient is sort of pushing also. Pelvis was also okay because you must have estimated the pelvis. Still, the baby is not coming down. Always suspect some fault in passenger, that is fetus. And the commonest that you should suspect, most dangerous one, should be macrosomia. And that is why anyhow head delivers, but shoulders fail to deliver. So to make a diagnosis of shoulder dystocia, be alarmed when there is prolonged second stage of labor. Second, be definite when there is difficulty to deliver face and chin. Be very, very definite when head fails to restitute. And turtleneck sign is diagnostic of shoulder dystocia. And when you apply gentle downward traction, there is no descent of shoulder. So then you see that you are dealing a case of shoulder dystocia. So now, um, how do we manage it? So we manage it with the help of mnemonic. Why mnemonic is important? Because it is an emergency condition. Not everybody is having, full visible and sensible senses to work. It is better to have these mnemonic dependent drills so that they are easy to reproduce, to learn, so that everyone, by hearts them and applies them when and where, as and when required. So the commonest mnemonic to learn is helper. So HELPER and R. So this E is just for this spelling. So H stands for health. So whenever you make a diagnosis of shoulder dystocia, always and always ask for help. If you have alarm system in your labor room, then go ahead, push that alarm button. And I'm sure every obstetrician is very good in shouting for help. So shout at the toppest of your voice and call for help. E means evaluate for episiotomy. So here you see that so evaluate for episiotomy. So evaluate episiotomy. A liberal episiotomy can be given, but yes, if the pelvic floor is wide, the patient is having lax perineum, then it's your discretion whether you would like to give episiotomy or not. But it's always good. It always helps. It creates more space in case you are failing in first order maneuvers. Then you for going for second order maneuvers, episiotomy is really helpful. Then L stands for leg. और कुछ याद रखने की जरूरत नहीं है. So leg. Leg का क्या करना है? There is a maneuver by the name of McRoberts maneuver. There you hyperflex the maternal legs and abduct them. So you are hyperflexing maternal legs and abducting them so that it increases the anteroposterior diameter of the pelvis and shoulder disimpacts and delivers through the vagina. So just remember leg and maneuver for hyperflexing this leg is McRoberts, which is a very famous, and as per literature, around 63 to 65% of the patients will deliver using this maneuver. Then comes the next P. It is known as external pressure or suprapubic pressure. So just remember P for pressure. और अभी तक we are just standing. Our help has arrived. We have abducted and hyperflexed the maternal thighs over their abdomen. And now, if we deliver by McRoberts maneuver, it's fine. If not, then the assistant, not you, the assistant applies suprapubic pressure from the side of the fetal back. So we always know what side the fetus lies, whether it is right or left. So suppose fetal back is towards left, you apply pressure over the suprapubic area from the left side, and it is being applied to the lateral aspect so that base acromial diameter of the fetus is reducing, it is compressing, and along with McRoberts maneuver, when we apply axial traction laterally and downwards, then we deliver the baby. We employ these leg and pressure maneuver both simultaneously to increase the efficacy. And there is no clear evidence that this is, first you do this, second you do this, or you do it simultaneously. Majority of the people are doing it simultaneously. But yes, if you have to remember the mnemonic and order, then if asked about order, then obviously first comes the leg maneuver, that is McRoberts, and then comes suprapubic pressure. Then there is another E, which is by which we mean enter. Enter means we are entering the vagina so that we carry forward the rotational maneuvers. So I'll talk about rotational maneuvers after this. So enter the vagina to perform rotational maneuvers. Rotational maneuver का मतलब क्या होता है कि you are entering, you are entering the vagina through your hand and you try to rotate fetal shoulder. और उसको rotate करने के तीन तरीके हैं that we will talk about. The next R is, if all these are failing, then you have to remove the posterior arm. And obviously in this also, after rotational maneuvers, if you're failing, then you remove the posterior arm. So this is very important. Don't be confused by these double R's over there. Removal of posterior arms. And some people say that this is better than rotational maneuvers. And finally, If posterior arm is not removed, which happens very frequently in obese patient, then you have to ask your patient to roll over to her hands and knees, and this is known as Gaskins. So this is known as Gaskins maneuver, where patient lies over her hands and knees. And remember, it is hands and knees, not chest and knees. Fine. So you don't have to be confused because there are so many mnemonics. Alarmer mnemonic है, बहुत सारे वेज mnemonic है. उसमें जरूरत नहीं है पढ़ने की क्योंकि लगभग लगभग हर चीज यही है. Helper is very easy to remember, and you if the reference for the teachings that I do is Royal College of Obstetricians and Gynecology, WHO guidelines, and Ministry of Health and Family guidelines. So by going by these three, helper is very cute and easy to remember, and I suggest using this mnemonic so that we all are managing our cases of shoulder dystocia nicely. So now a bit about what are the rotational maneuvers. Enter and do rotational maneuver. So I believe this helper mnemonic is clear to all. So I'll now talk about helper. So let me delete this. So as we talk of maneuvers, which are very important to remember in cases of shoulder dystocia, first we have discussed is McRoberts. What does it do? It straightens lumbosacral angle of the mother, rotates pelvis towards mother's head, and increases anteroposterior diameter of pelvis. And it is around 60 to 90% successful if done timely and by experienced persons. After you apply or you perform McRoberts maneuver, apply routine axial traction to the fetal head. If with McRoberts maneuver and routine axial traction, shoulder fails to deliver, then the assistant applies suprapubic pressure, which again reduces bisoacromial diameter of the fetus and rotates shoulder in oblique pelvic diameter, which is wider than anteroposterior diameter. Now, if these first line of maneuvers fail to deliver shoulder, you should go for second line of maneuvers, which can either be internal manipulation or all force position. So at this juncture, you completely ask the woman not to push, bring her to the end of the table, and either do Rubin 2 maneuver or Wood's corkscrew maneuver. In this, what do? We enter the wider posterior sacral hollow and we apply posterior sustained pressure on the posterior aspect of the posterior shoulder. And then we gently try to rotate it forwards, bring it to oblique diameter, which disimpacts the anterior shoulder, which is lying behind pubic symphysis, and thus you deliver it. Then Wood's corkscrew maneuver is in conjunction with Rubin's 2 maneuver. We apply the pressure from both the shoulders on both the shoulders if they are accessible, and for Wood's both the shoulders should be accessible. Then what do? You apply pressure in plus and minus direction on both the shoulders, and you rotate it, you disimpact it and deliver. If these maneuvers are failing, then delivery of the posterior arm can be done, where you introduce your thumb and first finger to the posterior shoulder, and with the middle finger, you apply a sustained pressure into the fetal axilla, bring out that arm into the straight angle, straight line, and then deliver the posterior arm followed by interior arm. And thus shoulder dystocia is managed. But if all these maneuvers, that is second line of maneuvers, are failing, then third line is either you perform maternal symphysiotomy or you perform clitotomy of the fetus, which obviously reduces the base acromial diameter. Or if it is not possible, then you push fetal head back into the vagina and perform a cesarean delivery. The incidence of hypoxia by this time is quite high, and there are increased chances of an ICU admission, morbidity, and even mortality of the baby. So the ideal detection to delivery time should be 5 minutes, although Nobody has given a very strict timeline for this, but yes, the aim of the delivery should be in 5 to 6 minutes. So with this, I would like to highlight one or two important things which you should not do. So, one, never ever apply fundal pressure if you diagnose a case of shoulder dystocia. Sometimes even uterine rupture cases have been noted after you fail to diagnose shoulder dystocia and ask assistant to apply fundal pressure. Second, you discourage the woman to uh, push down, because the more she will push down, more it will impact the fetal shoulder behind the pubic symphysis. So basically, these are the two things which you have to check and which you have to discourage on part of mother. And remember, helper mnemonic. H stands for call for help. E stands for evaluate for episiotomy. L for leg maneuver, which is known as McRoberts maneuver. P for suprapubic pressure. E for enter the vagina to do rotational maneuver. R for you have to sorry. So I think I was talking about the first R, remove the posterior arm, that is delivery of the posterior arm. And if that is failing, then roll the patient to her hands and knees, and it is known as Gaskin's maneuver. So few names of the maneuvers associated with shoulder dystocia, which are commonly asked in NEAT examination also. One is McRoberts, second is Woods, third is Rubens, and Rubens has two maneuver. One is done from the abdomen, pushing pushing the fetal back towards the oblique diameter. Rubin 2 is in when we go inside the vagina and we try to reduce the bisacromial diameter. And corkscrew maneuver is giving pressure both on anterior and posterior shoulder so that a corkscrew type of movement can be brought about and fetal shoulder is disimpacted. Then another maneuver is Gaskin's all four, where woman is lying in knee chest position. And finally is Zavanelli procedure, which is done to reduce fetal head back into the vagina and delivery of the fetus by cesarean section. Then it is important to remember the turtleneck sign, which is associated with diagnosis of shoulder dystocia. So if you have any queries, come back to me in comment section. I'll be more than happy to take that. Thank you.